So, in this segment, we're going to talk about risk factors and common comorbidities with atrial fibrillation. This is a terrific slide. This is the summary of all of the risk factors to develop atrial fibrillation. Incident AFib means new cases. And if you look at that middle part, these are all of the things we can't change, non modifiable risk factors. We can't change the age of the patient, we can't change the genetics, we can't change male sex, and we can't change your ethnicity. But all of the things that you see around that inner oval are things that we can intervene upon: obesity, sleep apnea, COPD, borderline hypertension that isn't being well controlled. All of these different entities, alcohol consumption, sedentary lifestyle, smoking, all of these things we have to really try hard to help get our patients to minimize these deleterious effects on the myocardial tissue, which will render it less susceptible to the atrial fibrillation arrhythmia. So we talked about the non-modifiable risk factors for AF. We talked about age. It sort of comes along with the territory of getting older. Our vessels get calcified and we have inflammatory processes and increased fibrosis. So all of these entities, we can't change genetics. We can't change the age of the patient. We can't change the sex. For some reason, men, poorly understood, have a higher risk of developing atrial fibrillation, but women seem to not do as well as men once they have developed atrial fibrillation. Strokes are usually more severe, and quality of life is worse. We know that the prevalence of AF differs according to race and ethnicity, and many, many population studies have demonstrated that AF, again, poorly understood, seems to be more common in white patients compared to Black or Hispanic. But important to think about, just like with women, the outcomes seem to be worse among racial ethnicities. What are the modifiable risk factors for AF? Commit these to memory. This is what we need to be doing in the office: cigarette smoking, alcohol consumption. Alcohol is a huge trigger for atrial fibrillation. Physical activity also. We got to get our patients out there, start walking, get your 210 minutes of cardio per week. That's not a lot when you think about it, 3.5 hours per week. We can do it. Several comorbidities, as we've discussed, increase the risk of AF, and I really want to talk about obesity. I don't think this was fully appreciated years ago. But excess weight, that adipose tissue, acts as an inflammatory source within the body. These are adipokines or like cytokines. They're inflammatory proteins. And we believe now that drives this increased risk of atrial fibrillation among individuals who are obese. Certainly poorly controlled hypertension, diabetes, all of these things, elevated glucose is deleterious for our vessels. OSA, obstructive sleep apnea, if you suspect that in a patient, snoring, daytime somnolence, morning headache, like all of these classic things that you learn, if your patient is stating that, the neck circumference, all of those things, get the overnight sleep study because it's important to get those patients on therapy. So the key takeaways for this section, that there's a wide range of non-modifiable factors, but there's a bigger range of things that we can hopefully intervene upon with our patient.